wanted to ask one final question about not even a specific abstract, but a theme that we saw a few abstracts about, and I believe is arguably going to be changing practice soon, and that is the concept of circulating free DNA, liquid biopsy, circulating tumor cells. Jean-Charles, I know in Europe there is an approved test for qualifying to get EGFR-based therapy, and it's based on serum testing. I don't know how much you've used it. How do you think that serum testing, both for EGFR, for acquired resistance, and potentially for a broader range of things, is going to affect the field? And I'll ask Lena afterwards.
Well, I truly believe liquid biopsies are going to be transforming the field. I mean, getting a needle in a patient in a metastatic setting is acceptable in the frontline setting. Doing this in a sequential manner when resistance kicks in, I mean, we do it in academic centers, but we have, kind of diplomatic immunity to get those biopsies in a, timely fashion. When you are in the community practice, you're going to lose 4 weeks, 5 weeks. If I can draw blood and get my results within 1 week, and who tells me, okay, you are T790M mutant, so give it a third generation EGFR TKI, or you are BRAF mutant. I mean, so many patients I see for second opinion, if I could draw blood, as I draw blood for chemistry and platelets, that will be a fantasy. And I think it's going to become a reality. And that reality is within our grasp, because it's not only about mutations. Translocations have been reported now by many companies. So I think this is great news for the patients.
And you and other people are regularly using the serum testing for EGFR, and it's effective?
Absolutely. We are using, in fact, in our institution, we're even using a panel of 35 genes. The concordance with tissue, the sensitivity is only 60%, but the specificity is 98%. So, I have a patient, if I cannot organize the biopsy, well, if you can do a test for 35 actionable mutations, it comes out positive, it's positive. Right. So I think this is going to change a lot of things. Community doctors might not need to call Lena and send the patient to Boston. They might draw blood, and only if he has the actionable mutation, they're going to call her and say, oh, you have this fantastic trial, why? Can the patient come in? It's going to save a lot of energy and time and decrease frustrations.
And we also need to bear in mind that the tissue testing is not 100% sensitive because of tissue heterogeneity. We know that you can biopsy one area and get a different result from another part of the same tumor, let alone the primary versus a distant metastasis in the adrenal gland or 2 different areas of lung lesions. So none of these approaches is a perfect gold standard. Lena, what do you think? And how soon is this going to become kind of widespread practice?
Well, I completely agree with Jean-Charles. I guess Europe is ahead of us. I wish we had it as standard practice here, but I think we are very close. And I completely agree that for the community, it's especially important. I actually work in our early drug development center as 50% of my effort. So I primarily get patients coming to Dana-Farber for consideration of clinical trials. And almost always the first step is, well, let's try to genomically profile the tumor to determine what's the best approach. And we're still doing it on a research basis. The testing takes 5 to 8 weeks once we receive the tissue from the outside institution. So many of the patients, it's really not even a viable plan. So it absolutely will be transformative, and I think we are very close. We are doing sort of studies to actually evaluate the feasibility of doing this and how quickly it can be done, how generalizable it is to the community, getting tissues shipped and comparing them. The turnaround time is a couple of days. And we don't use it to replace tissue biopsy data, but I think that it will.
I agree that having started to use it more and seeing truly practice-changing results in at least some of my patients, I think this is close to becoming a very big impact in the field, and certainly more convenient for docs and patients.
Right.
So, great. Well, I want to thank my guests, Jean-Charles Soria and Lena Gandhi, for joining me today. Really great discussion, and thanks for participating.
Thank you, Jack.
Thank you.